right. Hello and welcome to the Hormone Zoomer Boot Camp. This is the first of 5 sessions. Today's topic is the hormone matrix, mapping adrenal, sex, and circadian rhythm markers. My name is Adair Anderson. I'm the product and marketing educator here at Vibrant, and I'm going to go over a couple of quick housekeeping items before we get started, and also to allow folks to join into this webinar. All attendees are in listen-only mode. If you do have questions during the presentation, please submit them as a comment. We will have time at the end for Q&A. All bootcamp sessions are being recorded, and we'll be sending you a copy of the recording and the slides after the session ends. And now I am pleased to introduce you to Dr. Angela Mazza. Dr. Angela Mazza is a triple board certified endocrinologist and thyroid specialist known for her expertise in autoimmune thyroid disease and thyroid nodule treatment, including radiofrequency ablation. She's the founder of the Metabolic Center for Wellness in Florida and the author of Thyroid Plus, an integrative guide to thyroid health. Dr. Mazza combines clinical research, advanced diagnostics, and personalized care to help patients achieve metabolic and hormonal. Take it away, Dr. Mazza.
Oh, thank you so much for the kind introduction, Adair. I'm so happy to be here. I know you, I'm the first of a series of lectures on the Hormone Zoomer in this Hormone Boot Camp, and I'm just so thrilled to kind of roll it out for you. I am going to be talking mainly about adrenal and sex hormones, but you have some great lectures that are coming up, I'm sure. As Adair mentioned, I am an endocrinologist. So basically, that means I think about hormones the greater part of my day. So hormones are really super, very important because they are our body's chemical messengers. They influence everything, believe it or not, because our energy and our balance, our sleep, how we recover, our mood, our relationships, it affects our appetite, metabolism, resilience to stress, growth, reproduction, aging, you name it, our hormones are going to play a part. So whether it's cortisol waking us up in the morning, which we'll talk about, or insulin balancing our blood glucose, melatonin guiding us into some restful sleep, hormone balance shapes how we feel, how we function, how we grow, how we think. So hormones are so very important. And it's important to have reliable testing to look at hormones too, because yeah, there's no perfect test. Blood tests are only going to get us so far. They're really just a point in time. Salivary will give us more of an idea of free and bioavailable when it comes to certain hormone replacement therapies. But urine will really give us an idea of how our body's metabolizing hormones. So it'll give us that in-depth look into how our body is handling hormones. And that's why I'm so excited about Hormone Zoomer and all of the markers it's checking, because it really helps. It's really next level when it comes to personalization of hormone therapy. So here are our objectives today. And we're going to work to understand the daily cortisol-melatonin curve and its role in energy, sleep, and resilience. We talk about the cortisol curve a lot, but we don't talk about the three together. We'll learn how adrenal hormones link to progesterone depletion, as well as PMS and PMDD in cycling women. We'll review testosterone and epitestosterone ratios, how to flag those false low testosterone due to UGT2B17 gene deletion or therapy. And we'll look at androgen excess-driven symptoms that a lot of women and men may be experiencing, like hair loss, acne, mood changes. So mainly by using these urine metabolites. So let's get started. And it all begins when we're talking about stress with the HPA axis. So the hypothalamic pituitary adrenal axis, or HPA axis, is the central stress response system that regulates the production of cortisol and some other glucocorticoids. So it plays a vital role in maintaining homeostasis during stress. And who doesn't have stress? Stress can be emotional stress, infection stress, surgery stress, physical stress, and even stress of metabolic demand. So stress affects us all. But it all begins at the level of the hypothalamus, which releases corticotropin-releasing hormone, or CRH, in response to the stress signals that our body perceives. CRH, in turn, stimulates the anterior pituitary adrenocorticotropin hormone, or ACTH, and then in turn prompts the adrenal cortex to produce and release cortisol. So it's all a negative feedback loop, like a lot of the hormone systems in our body. So the adrenals are super important. They sit on top of our kidneys, and they have two distinct regions really. There's the adrenal cortex, which is the outer part of the adrenals, and the inner adrenal medulla. So each are responsible for producing different hormones that are essential for our survival. And again, it's all about homeostasis. So the cortex has three zones: the glomerulosa, fasciculata, and reticularis. So basically, it produces mineral corticoids like our aldosterone. So that affects our blood pressure and fluid retention, sodium. Glucocorticoids like cortisol, which we'll talk about in depth. Um, and that helps us manage stress, blood sugar, inflammation. And then androgens like DHEA, which is precursor to testosterone and hormones. So that's the cortex. And then the adrenal medulla makes those fight or flight hormones. So our epinephrine and norepinephrine. So together, these hormones all work in conjunction to control our metabolism, our immune response, our blood pressure, and our reaction to physical and emotional stress. So how does cortisol work? Well, cortisol works at the various tissues of our bodies to mobilize energy, to mobilize and upregulate inflammation in a good way. It's meant to be good. And then in turn influences our mood and our cognition. So we have this negative feedback loop that is so critical to how we live. I explain it to my patients. Cortisol is the most important hormone we have in our body. We need that one to live. That's our stress hormone. We can't live without it. So in the hierarchy of things, cortisol's top, thyroid's next, and then the hormones kind of go from there. It is important to review the steroidogenic pathway. So this all looks fairly straightforward. It's kind of a complicated pathway, but it looks very linear. But believe it or not, there's a lot going on all at once as far as enzyme reaction. But this is how our body takes cholesterol, because we actually do need some cholesterol, believe it or not. Cholesterol is converted into steroid hormones in the adrenal glands, the gonads, and then the steroid producing tissues that we're talking about. So cholesterol is taken in by the mitochondria, converted into pregnenolone. So pregnenolone, you might have heard, is called the mother hormone sometimes because it's the starting point for a lot of our sex steroids and our glucocorticoids and mineralocorticoids. So there's a number of enzyme reactions that are happening all at the same time. Pregnenolone is converted into hormones like cortisol, like aldosterone, like testosterone and estradiol, depending upon the tissue that we're talking about and the specific enzyme reactions that are going on. And this is very tightly regulated, even though lots of things are going on at once, but it's very tightly regulated by that HPA axis. So when there's defects in these pathways, it can translate to big changes from a clinical standpoint. Now, this is a very, very simplified HPA characterization. So cortisol, as I mentioned, is our most important hormone. It ideally should be highest first thing of the day with a gradual decline towards the end of the day. And it shouldn't be high all day long. It shouldn't be shifted down. It shouldn't be backwards where it's high at night. It really shouldn't be low all day long. And this is what patients are, when they come in and they're complaining of fatigue, this is where my brain goes to first. What's going on with their cortisol axis? And where can I make adjustments to help reset this HPA axis? Because it's not like the adrenals are tired, the adrenal fatigue, that's what we talk about with time. It's not adrenal fatigue. The adrenal glands are not tired. It's that the axis is dysfunctional, if you will. Our brain, if you think about it this way, our brain can't live at a very high level of cortisol all the time or for very long periods of time. Because basically our hippocampus says, whoa, this is like brain on fire. We need to survive. We need to downshift. So that's where we see the downshift of the curve. And then in very bad circumstances, we see a very flat curve. And this flat line rather, is not even a curve, is always worst case scenario when it comes to HPA dysfunction. In the studies that we look at this, Patients with cancer always do worse. Patients with cardiovascular disease always do worse. This is worst case scenario. We want to catch things early, and that's the importance of hormone testing. I want to just touch base because I hear the term Cushing syndrome thrown around a lot because I think there's some misunderstanding sometimes. So the term Cushing's disease, Cushing syndrome, and HPA axis dysfunction, they all involve dysregulation of the HPA axis and cortisol, but they're different causes and mechanisms. So Cushing syndrome, by definition, is a clinical state resulting from chronic high exposure to high levels of cortisol, regardless of the source. So most of the time, it's going to be an exogenous source. So long-term use of corticosteroid medications like prednisone, like persons who are on prednisone for a long time, or dexamethasone or hydrocortisone. So these are all different types of steroids. Less commonly are endogenous causes of too much cortisol. So this is going to be like Cushing's disease. The only form of Cushing's disease there is but due to a pituitary tumor that makes too much ACTH. There can be adrenal tumors that make too much cortisol less commonly. There's ectopic ACTH production from lung cancer sources. Um, but usually when we're talking Cushing's disease, it's going to be a pituitary tumor. And the symptoms are the same for Cushing's syndrome, whether it's due to exogenous or endogenous. So it can be weight gain, really in that belly section, a moon face or full face, abdominal striae, which they can kind of look purpley, high blood pressure, cortisol or glucose intolerance, muscle weakness, muscle loss, really, and mood changes. So Cushing's disease, if it is due to a pituitary tumor, usually we treat the tumor. Now, HPA axis dysfunction is a functional dysregulation of the HPA axis, often due to stress and altered cortisol patterns, but it's not the same as Cushing's disease or Cushing's syndrome. This is due to chronic stress and a maladaptive HPA axis. This leads to abnormal cortisol output, which either can be low, high, or dysregulated. So there's a distinction there, and the diagnosis is different too. So we usually look for HPA axis dysfunction with salivary cortisol testing or even urinary cortisol testing. And the treatment's going to be mainly lifestyle, nutrition, stress management. It sounds easier than it is, but it's pretty tough. Whereas Cushing's syndrome is taking away the source of the excess cortisol. Now, stress. Let's talk stress. Who does not have stress? I talk stress with every single one of my patients when they come in the office. Stress and sleep, those are two of the main things I start with. So stress triggers a cascade of these physiologic responses that begin at the brain and they ripple through the body, primarily through the activation of the HPA axis. So in response to a stressor, we see this axis is enacted. Now, the evolution of the stress model as we know it has kind of changed over time. We kind of look towards history. The general adaptation syndrome was originally constructed by Hans Selye, who was the father of stress research. And he proposed this to kind of describe how the body responds to stress. So this was back in 1936. And if you look at the timeline of history back then, I mean, you can imagine it was a pretty stressful time because it was after World War I, it was before World War II, and the Great Depression fell right into that timeline. So stress was pretty big back then. This laid the foundation for his book afterwards, and we used it as a framework to explain adrenal dysregulation, where the adrenal glands don't manage cortisol output properly. We now know that it's not the adrenal glands' fault. And this had 3 stages. So it was the alarm stage, or arousal, when the body perceives the stress that activates that fight or flight response. We release high levels of cortisol, epinephrine, and norepinephrine, and patients may have higher heart rate, heightened alertness, rapid breathing, increased energy. People don't usually feel too bad when they're in this level. Digestion slows down, But then there's the resistance stage, which is adaptation. So that if the stressor continues, the body does try to adapt. Cortisol may remain elevated, may begin to drop. DHEA is a good kind of monitor in this time too, because DHEA tries to help our body balance that cortisol, and it will go up as well, but it will start to decline before the cortisol does. The body still stays alert, but it's less acute. So this is where people may start to have irritability or mood swings, fatigue, despite feeling like they're sleeping. We start to see blood sugar imbalances, high anxiety, depression, a weakened immune response. People who are under a lot of stress get sick a lot. They catch all the bugs that are going around, and I see this in my patients all the time when they're under stress. And then there's finally the exhaustion stage. So this is where we see low cortisol and DHEA. So this is where the severe fatigue sets in. This is where that curve starts to get downshifted and flattened. So we see brain fog, memory problems, depression, low libido, um, blood pressure dysregulation, craving and stress eating we see it during this stage. So those are the three stages of the general adaptation model. This has kind of changed over time to evolve into more of a homeostasis model. So the homeostasis model of stress really views stress as a disruption to the body's internal balance, that homeostasis. Our body wants to stay in balance. And it describes how the body just fails to adapt or fails to um, regulate in response to the demands on the body. So these stressors. And it really reflects the body's ability to cope, its resilience. So homeostasis, like I mentioned, is kind of that balance we're shooting for, how we respond to stress and get back in balance. Now, there's different types of stress. So there are good stresses out there. There's positive stress, that's eustress. Positive stresses actually help us grow, help us challenge, help us get better, really. They lead to growth, adaptation, performance improvement. So, you know, everybody has their own example of good stress. I mean, maybe it's just kind of getting that job that you really wanted, or getting ready for vacation, or even if you're shopping for, you know, this cool pair of shoes or something, and you find those are the ones that you want, score. That's good stress. Now, negative stress tends to be uh, exceeds the body's ability to adapt. So that's when we see dysfunction. So that's kind of the chronic stress. That's the caring for caring for a sick parent stress, or caring for a sick child for that matter, that type of stress, or financial stress, or stressful work situation. So those are the things that tend to go on for a long time. They're the wear and tear on the body. That's what really affects resilience. And then, believe it or not, there's something wrong with not enough stress either. So that's the insufficient stress or sus stress. So it's just lack of stimulation. And a sedentary lifestyle can fall into that, lack of cognitive stimulation. So there's good, we're looking for the right amount of stress, if you will. So HPA axis dysfunction is really what can lead to chronic disease. So that, like as I mentioned, short-term stress can be adaptive. It enhances our alertness, it enhances our energy, it enhances our immune system. But chronic stress leads to dysregulation. So this leads to those levels that we don't want. And we can see with time this has a wide range of downstream effects. So we see an increased risk for cognitive, emotional, behavioral dysfunction like anxiety, depression, memory problems. We see an increased risk for cardiovascular dysfunction that can go along with hypertension and vascular disease. We see an increased risk for immune dysfunction. So, I take care of a lot of persons with autoimmune thyroid disease, and oftentimes stress is that final trigger that kind of pushes a person into an autoimmune spectrum. And in the case of autoimmune thyroid disease, like Hashimoto thyroiditis or Graves' disease, we see these increased circulating cytokines and in themselves aren't great. We see chronic and low grade inflammation that's ongoing. And then we see a risk for other things like diabetes. Obesity is a big one. Obesity is a very inflammatory state, and it can be directly related to cortisol over time. So HPA axis dysfunction isn't just stress. It's a risk for chronic disease down the line. And it's something that as clinicians we need to recognize. We need to address this with our patients because that could be the difference between them having a chronic disease and not down the line. Because in essence, HPA axis dysfunction is a key bridge between chronic psychological stress and long-term physical disease. So it is important to recognize. All right. So where do we even start? So testing does help us out. Um, Looking at cortisol does help us out. So we talked about cortisol curve, but cortisol also gives us some information too. So whereas cortisol is kind of like our get up and go hormone, it should be highest first thing in the morning, as I mentioned, to kind of wake us up and give us energy, but it really should decline towards the end of the day by the time we go to sleep so we can kind of get ready for bed and rest. Whereas cortisone is really a buffer. So it's an inactive form of cortisol. The body can convert cortisol and cortisone depending upon what is needed. So cortisol and cortisone are both glucocorticoid hormones. They're both involved in the stress response, although we always talk about cortisol. But they differ in their biologic activity and function. So cortisol is the biologically active form. It's actually the active form. But cortisol, on the other hand, is the inactive form, and it really serves as a reservoir that can be converted back into cortisol when needed. So it's that back and forth between cortisol and cortisone that gives us some information what's going on in the system. And there are enzymes that regulate this. There's the 11 beta hydroxysteroid dehydrogenase enzymes. There's a type 1 that it activates cortisone to cortisol, and there's type 2 that inactivates cortisol to cortisone. So it's this back and forth. And this balance really helps the body fine tune cortisol activity in specific tissues. So you can think about you don't want your kidneys to be exposed to cortisol all the time, right? We want to protect the kidneys. So we don't want excess cortisol. And disruptions into this process really do lead to metabolic issues, inflammatory issues, and other of those stress related conditions that we were talking about. So as I mentioned, the 11 beta hydroxysteroid dehydrogenases can give us insight into what's going on. So the type 1, remember, converts cortisone to cortisol. Type 2 converts cortisol to cortisone. So what would cause an increased ratio between 1 to 2? So inflammatory diseases, joint conditions, neurodegenerative diseases, metabolic diseases, cognitive decline. All the things that we really think as far as bad things with chronic disease are going to cause a ratio that's higher, 1 versus 2. Certain drugs can, certain foods can, certain herbs can. Glucocorticoids, of course, can. But things like even grapefruit juice can, licorice can. So synthetic disruptors, and that's part of the hormone Zoomer testing, can cause an imbalance here where we have more type 1 than type 2. But on the other hand, things that promote type 2 versus type 1 are hormones. So estrogen, progesterone, thyroid can, pregnancy can too. And there's supplements, drugs, and foods that can also upregulate type 2 activity. So that's going to be like green tea, coffee, basil, curcumin, vitamin A. So these are all things that can flip the ratio the other way. And then finally, important to take into consideration, we're talking about circadian curves, is melatonin. So melatonin, as you probably already know, is primarily produced in the pineal gland of the brain, plays a central role in our sleep-wake cycle, our circadian rhythm, and is closely linked to the light-dark cycle. So it rises in the evening as it gets dark, peaks at the night, and then drops in the morning as we're exposed to light. So melatonin signals the body, hey, it's time to sleep, it's time to rest, it's time to repair and regenerate for the next day. So, but beyond that, melatonin also is a potent antioxidant. It supports our immune function. influences our reproductive hormones and influences our metabolic health in a positive way, and even influences cellular repair. So disruptions in melatonin can affect our overall health. So we kind of look at this in conjunction with cortisol and cortisone. So these patterns in general are really uh, regulated by the suprachiasmatic nucleus, the SCN of the brain, and this responds to light. So light suppresses melatonin and boosts our alertness. So we, like I said, cortisol should be highest in the morning, should be lowest towards the end of the day, and vice versa for melatonin. So knowing what curves we have, what we're dealing with, can as a clinician help tailor our recommendations for our lifestyle recommendations, dietary recommendations, as well as supplements. So things that can increase melatonin, obviously, if you take melatonin, it can. Um, Supplements like 5-HTP can. Um, but there are causes of decreased melatonin too. So in our 40s, unfortunately, melatonin production can begin to decline a little bit. But exposure to the blue light from screens can too, and EMFs, uh, renal disease, hepatic disease, ophthalmic disease, spinal cord disease can also impact melatonin production. And then medications like beta blockers, um, NSAIDs even can, benzodiazepines can. So there are a lot of things that can affect not only cortisol, but the ratio between cortisol and cortisone, as well as melatonin. So what can we do to help reverse the curve or optimize our curve? Where to even start? And these are all kind of basic things that as integrative doctors and practitioners we try and shoot for. Um, Fixing the melatonin cortisol imbalances involves we want to restore that circadian rhythm. So we want to try and help our patients target lifestyle and environmental strategies that may be negatively impacting them. So, reinforcing a consistent sleep wake schedule is super important. I know how challenging it is. I just had a patient earlier today. She is a freelance worker. So, her schedule is all over the place. So, trying to come up with a consistent wake schedule is tough to do. So we have to take advantage of what we have control over. So with her, we try and get it to within a certain window. It's a challenge, but we have to work with what our patients are living with. Um, we if you can expose yourself to that bright natural light in the morning. Again, not everybody can do that. In an ideal world, we'd all get up, walk outside, see the sunrise, see that blue orangey view, ground our feet. In an ideal world, that would be wonderful. Not everybody can do that, but those who can should. At night, you want to limit the blue light exposure, especially from our phones or computers, if we can. Uh, Cut back on caffeine after a certain time. Have that caffeine curfew. Try and get in relaxation practices like yoga, meditation. I'm a fan of magnesium at night. So, magnesium's a great way of kind of helping the body relax and get ready for bed. There's adaptogenic herbs that we can use, short term melatonin supplementation when needed, and if it's indicated. So, there's lots that we can do out there to help our patients, but it is going to be if there was a one size fits all, it would be so easy, but everybody's schedule is different. Everybody's living environment's different. So we just do our best and make suggestions where we can. There are a number of nutraceuticals out there that are helpful, and this isn't even a complete list. Ashwagandha is great. L-theanine is great. GABA works off the GABA receptors. Rhodiola, adrenal extract blends. Adrenal adaptogens, I would be careful with. It depends upon what the cortisol curve looks like. So you definitely need information before you recommend um, adrenal adaptogens, especially an adrenal extract blend. Chamomile, lemon balm, cordyceps, magnolia, philodendron, CBD, all great nutraceuticals to consider in the right patient. So, what are we shooting for with optimizing this curve? Well, there's lots of benefits. Um, one of the benefits is a healthy cortisol curve means high energy in the morning, good performance throughout the day, and a natural drop towards the evening. Good sleep. Melatonin needs a low cortisol environment to be secreted properly. So, if cortisol is not adjusted, then melatonin can itself be affected. Because if cortisol is too high at night, melatonin production can be blocked. So they go hand in hand. And then resilience. Resilience is what we're all shooting for because we know we're all going to be exposed to stress. So if we can help our bodies adapt to stress, recover from the challenges that we're being faced with, bounce back as best as we can, it will affect our allostat. Will affect how our body responds to that allostatic load. All right. So let's move on to um, adrenal hormones and progesterone. So progesterone, uh, super important. It's, in women, it's made in the corpus luteum of the ovaries after ovulation. We make even a small amount, some women do, after menopause, and a small amount in the adrenals. But beyond reproduction, progesterone has so many calming, anti-inflammatory, and neuroprotective effects. And I have so many female patients on progesterone just because I've seen how it works firsthand, and it does make a difference for a lot of women in the right scenario. It can affect mood by interacting with the GABA receptors of the brain that kind of cools off the neurotransmitters in the brain, producing a sense of calm, helping counteract anxiety. It can help with sleep. It has a lot of benefits. It helps balance the effects of estrogen. So estrogen is a wonderful hormone. We love estrogen, but it can be inflammatory. So progesterone helps balance that. Um, but you know what? Men make progesterone too, and I don't think we talk about that enough because although it's a lot smaller amounts than women, progesterone for guys is primarily produced in the adrenal glands, tiny bit by the testes, but it has several important roles for guys too, and it acts as a precursor for other hormones like testosterone and cortisol in some effect. Progesterone also has a calming effect for guys as well as women, and it really just helps balance hormones in general. It has important brain health benefits and anti-inflammatory benefits for guys as well. So, we kind of overlook the benefits of progesterone sometimes, but progesterone is very important. And I just keep it on your radar um, as far as one of the hormones that is a I kind of say it's one of my favorite hormones. So progesterone does play a role in PMS and PMDD, so premenstrual dysphoric disorder rather. Um, so progesterone, where I talked about, it plays a part in mood, sleep, neurologic, anti-inflammatory. But when we look at the cycle of a woman's cycle after ovulation, um, progesterone levels rise to prepare the uterus for potential pregnancy, right? But if conception doesn't occur, these levels do drop off, and they can drop off pretty sharply and can cause some symptoms in a lot of women. So it's this withdrawal, especially if this progesterone is drops and it's very low related to estrogen. A woman can have symptoms like uh, real irritability, uh, bloating, breast tenderness, lots of just feeling inflamed in general. If you ask your female patients and they're dealing with this, they'll just say, I just feel inflamed." And it can be more severe with women with PMDD. So just kind of keep that in mind because you're losing that beneficial effect of progesterone. Sorry. So, um, you can oftentimes see spotting during the luteal phase. So that's the phase right before your cycle for a woman. So stress, specifically during that luteal phase, can cause spotting. So this can be alarming to a woman, but it's really due to disrupting the delicate hormonal balance that's needed to maintain the uterine lining. And this is due to progesterone, which is essential for maintaining that lining. So unfortunately, when we're dealing with acute or chronic stress, um, when we activate that HPA axis, this leads to an elevated cortisol. That elevated cortisol interferes with GnRH, our gonadotropin releasing hormone. And we also oftentimes subsequently see a reduction in LH as well as a subsequent decrease in progesterone. So, unfortunately, insufficient progesterone, this is often called a luteal phase deficiency, results in spotting before the expected period. And this also may be called progesterone steal, and may further exacerbate this imbalance. So, addressing stress really can make a big difference in supporting the adrenal and ovulatory function. So, um, stress during the luteal phase can lead to spotting, and it is reversible. Okay, so progesterone can be converted. It has two metabolites. So there's 5 alpha and 5 beta pregnenolone. So um, what's the clinical relevance? Well, first off, if we are measuring progesterone, usually you measure it in serum, whereas you can measure the metabolites in urine. And looking at the ratio between these metabolites gives us some really, really good information. So 5 alpha and 5 beta pregnenolone, um, well, they're the clinical relevance lies in how the different distinct pathways of progesterone metabolism. So 5 alpha is produced by the 5 alpha reductase pathway, serves as a precursor to allopregnanolone, and this is enhances GABA activity. So that produces that calmness, that stability. Whereas 5 beta is formed by a 5 beta reductase pathway. So this does not convert into those neuroactive metabolites, and this tends to be upregulated in oxidative stress. So looking at these ratios gives us an idea of what's going on from further. Say you were just checking a serum progesterone, what's actually this progesterone being metabolized into, and what's the ratio? Because 5 alpha is a little bit more beneficial on mood. So, 5 alpha pregnenolone, really, if we look at it, is more beneficial to mood. I apologize, and that's going to help stimulate the GABA receptor better. So when we look at urine studies for the two of these, we can look at a ratio and say, all right, what what is actually going on as far as promoting the best that we can for our progesterone. So, what are causes of low levels? Well, it can be even just aging, suboptimal clearance of our other metabolites. So, there's a lot of factors at play. So, again, what are the beneficial effects of 5 alpha pregnenolone? Um, it's really just more calming. It's going to help out our female patients as far as um, just their how they're metabolizing the progesterone. Okay. Now let's move into estrogen. So, so progesterone, we said pregnenolone can be converted into progesterone, but it can also be converted down the pathway of DHEA to estrol. It can be converted down to estradiol or E2 or estriol E3. So there's three different forms of estrone. Estradiol is our most beneficial estrogen. It has all the good things when you think of in terms of bone health, brain health, and heart health. Estriol does to a certain extent, but estrone not as much. So when there's too much estrogen, we can have issues. Like I mentioned, estrogen is a wonderful hormone, but too much is not so good either. So whether it's due to overproduction, impaired detoxification, a relative progesterone deficiency, so we can have a wide range of symptoms that do affect um, estrogen excess. So kind of some of the symptoms we see with PMS symptoms, so bloating, breast tenderness, but it can lead to heavy cycles, um, weight gain, water retention, fibrocystic breasts, uncomfortable menstrual cramping. So estrogen excess can cause a lot of symptoms in a lot of different women. So how do we tell the difference between high estrogen or is it low progesterone? Well, while high estrogen and low progesterone can cause similar symptoms, high estrogen often is related to an excess of estrogen in the body. Well, whether it's like obesity, poor estrogen detoxification, xenoestrogen exposure, so those endocrine disruptors can play a part. In contrast, low progesterone um, we usually see that in terms of luteal phase defects, age-related decline, or that chronic HPA stress that we were talking about. So it's tough to tell. Progesterone does have that calming, stabilizing effect, but when it's not there, and we have excess estrogen, it can be quite systematic for women. But nonetheless, really, symptoms can be the same, and the symptoms oftentimes overlap. So it's the ratio that really matters. So we have to look at estrogen dominance and too much estrogen, too little progesterone, and if we can look at ratios. So that's where urine studies help us out to say, all right, is this an actual estrogen dominance type of picture or estrogen excess, or is it low progesterone? So that's where testing comes into play because these women actually are going to present quite similarly, aside from a couple small nuanced differences. So, what are ways that we can help balance estrogen and progesterone? Well, there's a lot of different things. Um, if we can, well, the benefit of balancing this would be to for healthy ovulation. So, if a woman's pursuing fertility, we want to have a healthy balance between estrogen and progesterone. We want to be optimizing our detoxification pathways, and those triggers that play a part come back to stress, inflammation, and not to mention endocrine disruptors. So, to support progesterone, we want to really work on getting in adequate nutrient intake, stress reduction, blood sugar regulation. Chronic stress is really a player here. But there's lots of other things that we can do, and other tools in our toolbox that can help us out. Um, Increasing fiber. So fiber, making sure our female patients get enough fiber. So 30 grams of fiber a day is what's recommended to help support the estrabolome. So estrabolome is the microbiome that helps us recycle estrogen and clear out estrogen metabolites. Crucifer spedules. So all you folks that love green veggies and crucifer veggies, it's going to be helpful to help detoxify high estrogen rather. Limiting alcohol, maintaining a healthy weight, avoiding those xenoestrogens when you can. On the other hand, if we can support progesterone by stress management, healthy fats, zinc, uh, B6, magnesium. So these are all great ways of helping to support progesterone. Other ways to support this balance are our nutraceuticals and our medical treatment. So, progesterone cream can be a way of providing some extra uh, progesterone support. Bioidentical therapy can help with balance as well. Using micronized progesterone, as far as using that in a premenstrual syndrome or PMDD situation, I generally recommend just dosing a micronized progesterone 10 to 14 days before the estimated cycle. Usually it's about 100 to 200 milligrams a day. From a nutraceutical standpoint, my go-to is always DIM. So DIM essentially is like 5 bowls of cruciferous veggies all together and sulforaphane that help clear out estrogen metabolites. Uh, Chasteberry is a great way of doing it, and uh, calcium D-glucarate. Okay, so next, what about our testosterone? So we can also have pregnenolone be converted down to androstenedione into testosterone and its metabolites there. So testosterone, we know, is a steroid hormone produced in testes in men, ovaries and adrenal glands in women. We always talk about how important it is for guys, but it's super important for women too. Helps maintain muscle mass, bone density, libido, mood, cognitive function, as well as metabolic health. So it is very important. Testosterone, again, it helps. It's kind of one of, I think, is a great, it's great for motivation, energy, and just overall sexual well being. We always talk about testosterone with guys, which it is very important. We want to make sure our testosterone levels are optimized. But in women, it can be a real game changer too. So I have a number of women who we do treat with testosterone, and they say it's like night and day when it comes to even just brain function. We do see some levels naturally decline with age, but again, chronic stress, inflammation, insulin resistance can affect testosterone production. Of note, whenever we're diagnosing low testosterone, especially in men when levels are very, very low, we want to make sure we're not missing anything from a pituitary standpoint that is influencing testosterone levels. Um, but what are symptoms of low testosterone? Well, um, fatigue, low libido, muscle loss, mood changes, poor concentration. So, testosterone does play a huge part in how we feel, and it's important for men and women. Now, epitestosterone is like the mirror image of testosterone. It's also naturally occurring, has the same molecular formula, but has a different arrangement. Unlike testosterone, epitestosterone has minimal androgenic activity. I mean, it doesn't significantly activate androgen receptors. Um, and doesn't contribute, it doesn't really contribute to the typical testosterone effects like muscle growth or libido. It also is produced mainly in the testes and adrenal glands, um, but we use it in a couple different instances. So the testosterone to epitestosterone ratio is commonly used in drug testing to see to kind of give an idea of uh, doping or illegal use of anabolic steroids. So a ratio that's higher than 4 to 1 may suggest some external testosterone administration because epitestosterone doesn't really have a major physiological role. It may actually be a natural modulator, but it gives a marker of actual testicular and adrenal function, where epitestosterone does not. So a normal range is going to be 1 to 1 in most individuals. Less than 4 to 1 can be normal and physiologic in certain realms, but abnormal is greater than 4 to 1. So that may suggest some exogenous testosterone use or abnormal endogenous production. So these ratios just give us an insight into what's going on. Now, it can also play a part in this gene called UGT2B17. So what is this gene? So um, this gene is a key gene that encodes an enzyme responsible for glucuronidation of testosterone. So glucuronidation is really a metabolic process, attaches a glucuronic acid on and makes it water soluble and allowing it to be excreted in the urine. So if you don't have this gene, urine testing for testosterone is not going to be accurate. This is kind of a clear example of when you would have to use blood testing because um, if you have the gene deletion, they don't produce. There's no there's no enzyme there. So this leads to a reduction in the urinary testosterone. So again, you wouldn't be able to measure in the blood or in the urine. So you have to get a blood test in this specific instance. What are signs of too much androgen production in women? Well, it can be a variety of symptoms. Most of them tend to circle around hair, skin, and menstrual cycle, as well as somewhat in metabolic health. So, women can experience or have measured levels of too much testosterone, DHEA, or androstenedione. Um, a woman coming in with complaints of too much testosterone is going to be usually hair loss or hair growing in places they don't want it growing, acne, and usually some irregular cycles in menstruating women. So, what are the causes? Well, PCOS is a cause, polycystic ovarian syndrome. So, polycystic ovarian syndrome is a syndrome. So it's diagnosed by 2 out of 3 criteria, which are irregular cycles, too much testosterone, or signs of too much testosterone, or increased cysts on the ovaries. Interestingly, insulin resistance isn't a qualification for PCOS, although in a lot of women does play a huge role. Uh, Congenital adrenal hyperplasia can be a cause. That's diagnosed mainly by measuring DHEA levels or DHA sulfate. So DHA sulfate's a better measure in the blood. So those are kind of the most common cause of too much uh, testosterone in women, aside from the fact if they're on medicines, that would be causing it. Now in men can also have symptoms of too much testosterone. It's not as common, but it can be due to too much testosterone dosing, anabolic steroids, testosterone secreting tumor. So those are things you don't want to miss. But main symptoms they may be having could be mood changes and irritability, again, oily skin, can be gynecomastia because testosterone gets aromatized to estrogen and can cause some breast development. Too much red blood cell production. So we don't want blood to be too thick, but when testosterone is high, it can stimulate red blood cell production. It's always so important to monitor hemoglobin, hematocrit, anyone who's on testosterone replacement. Now, 5 alpha reductase. So 5 alpha reductase dominant refers to how steroid hormones are metabolized, particularly progesterone and testosterone. So this can influence how much dihydrotestosterone from testosterone is produced. So DHT. So when we have a high level of DHT, that can cause more of the kind of virilizing effects of testosterone. So for women, that can be more acne, more hair thinning, more hirsutism, but their testosterone levels may be completely normal. We oftentimes see this a lot in PCOS where the testosterone levels are normal, but they clearly have some androgenergic excess, and that's where measuring a DHT may be helpful. So where does urinary metabolite testing come into this? So it actually is a really comprehensive way of assessing androgen excess because it measures, the parent hormones as well as those downstream metabolites. So it gives you more an exclusive, except in the case of UGT B17 deletion, it can help us figure out how much androgen is produced, how it's being metabolized, where it's coming from. It just gives us that extra insight into what's going on um, in metabolism of hormones. It helps us look at the breakdown products as well. It helps us figure out a game plan because in functional and in integrated medicine, we always we don't want to guess. We want to have a game plan that guides our our recommendations. Now, urinary metabolites, how do we even look at this? Well, here's kind of a really simplistic guide of looking at urinary metabolites. So if we have a lot of DHEA sulfate metabolites, again, DHEA sulfate, if you're measuring it in the blood, is actually a better indicator. It's more stable, it's more reliable. But if you do have high DHEA and DHEA sulfate metabolites, think adrenal origin. So think PCOS or some sort of adrenal hyperplasia, specifically in women. If you have high testosterone, high androsterone, think ovarian or systemic androgen excess. So kind of gears you in a different pathway. If you have high levels of 5-alpha metabolites, so this suggests that DHT production, so that's going to be linked to more of the acne, more hair loss, more hirsutism. So that's going to be the cause of your patient's symptoms. If you have a 5-alpha to 5-beta ratio, so this suggests that 5-alpha reductase activities. So that again is linked with more virilizing symptoms. So it really just gives you that extra insight that as an integrative physician, your traditional colleagues are going to miss. So what are the clinical uses for this? Just like I mentioned, it really helps us figure out what's going on. It helps to differentiate the ovarian versus the adrenal sources, helps assess DHT-driven symptoms, helps evaluate 5-alpha reductase activity, and then it helps us monitor treatment response. So we covered a lot of ground. So the takeaway points, and without running over it, to address adrenal health and stress is essential because stress really impacts everything. If we're not addressing stress, there's so many clinical symptoms that we could be mistreating. In integrative medicine, we really want to get to the root cause of what's going on. And if we're just giving someone testosterone or just giving someone hormones without looking at what's going on at the level centrally at the axis being impacted, we're not really fixing anything. And honestly, you're not going to get really far um, in your treatment success. Maybe temporary, but your patients are going to come back feeling uh, not to their optimal self again. Stress not only impacts cortisol, but also those sex steroids as well as their metabolism. So it's not just the distinct level of their hormones, it's also how they're metabolized. Understanding how stress and sex steroids are metabolized, we can better understand how to approach rebalancing them, which is essential. And then using those urinary metabolite testing of these hormones is key to developing a personalized treatment plan because the more you work with this testing, the more you get a feel for it. You really are using the testing to help support guide your hypothesis. So, who do we want to order this testing on? Well, you know, you can order it for preventative reasons. You want to see what are your patient's risk of developing something down the line. That's a key. You can run these tests to help kind of reevaluate or establish a personal baseline. And they're good for both men and women at different stages of their lives. So um, I appreciate your time. I know it's a lot of information, but uh, I think we have some time for questions if that's possible. Thank you for your attention.
Thank you so much for that. Wow. Like drinking from a fire has amount of information, Dr. Ryan.
It's a lot. I'm sorry.
So since we are short on time, I'm going to go through what been going through the question. Usually we go from top to bottom, but there have been some repeat questions where people really had interest in a certain topic. So we're going to start with those, and if there's extra time, we'll try to get to all the other ones as well. We're going to
Fabulous.
start with probably just a really short answer question here. How often should you test hormone levels?
That's a great question. If you're, sh- I kind of always look at, it depends upon the hormone we're interested in, first off. Um, if you're looking at just the metabolism, I think every 6 months to a year is a good idea, especially if you're changing, treatment. So if you're changing treatment, you really wanna evaluate at least every 6 months. If things are pretty stable and you're kind of following your kind of just routine follow-up, if you're following systematically, everything's going well, you're doing your routine lab work, which is important too. Um, I think once a year for doing something like a extensive metabolite testing is fine. But if you're changing treatment, it's always important to reevaluate.
Absolutely. Because you don't want someone having too much estrogen or not
No, no.
finding it sooner is better than later.
Yeah, and it gets harder to fix things if you wait longer. So, and because patients will be like, "Oh, I feel fine. Do I have to come back for reevaluation?" Yeah, because we want to target things ahead of time without having to backtrack and restart from square one.
Absolutely. Next set of questions all about progesterone, specifically high progesterone on day 21. Um, like, are there any contraindications for having high progesterone on day 21? And what is the other one? Could you please speak to symptoms or consequences of having elevated progesterone?
Okay, so symptoms of elevated project. So honestly, I kind of take everybody individually. If you're checking a level and it's high, I mean, it kind of takes in you have to take into consideration the patient themselves. If they're not having any issues, then I'm not too concerned about it. Um, if they're on some sort of progesterone replacement, then you may want to think, hey, maybe I need to cut back. Um, Symptoms that someone may have, you know, I find it's more of a fatigue issue, more of a sluggishness, sleepiness, kind of brain
Mhm.
foggy issue when there's too much testosterone or progesterone rather.
Okay, that's good to know. On that related note, um, Is there is it best when is it best to try and increase if someone has low progesterone? Should you do it during the follicular phase? Should you do it during the luteal phase? And the second follow-up to that, does DIM exacerbate low progesterone in a patient who initiated treatment without testing?
Oh, great question. So multiple parts. So I initiate progesterone during the luteal phase. So what I will say is I usually you can and I didn't mention this, you can compound a sustained release progesterone as well as doing a micronized progesterone. I usually start with a micronized progesterone just because if we're in the interest of using a patient's insurance, I mean, most of your insurances will cover progesterone. And ideally, you want to pulse the progesterone. So doing it right before the cycle, that 10 to 14 days is going to be optimal. Now, do I ever have patients on progesterone throughout the month? Sometimes. Sometimes if people are doing well on progesterone, they really need it for sleep. They're really having a lot of night sweats. Night sweats are a big thing. Persons with low progesterone. I will do a sustained release compound, and I'll even sometimes do a lower dose throughout most of the month, and then a higher dose that 10 to 14 days before.
Mhm.
DIM. I like I said, I love DIM. I don't have any issue with it causing any problems with people on progesterone. No, it just really helps clear out that high inflammatory state that goes along with high estrogen. Um, that you can take it all month long. It's a great detoxifier in general.
Okay. And your target population for progesterone support, is that like the menopause, perimenopause category? And would it be contraindicated for someone who's trying to get pregnant, for example, like
Great
that
question.
during a
That's
follicular phase can prevent that, right?
right. So, well, perimenopause and menopause, yes. I mean, without a doubt, progesterone is it's beneficial in the right person. In someone who's trying to become pregnant, I don't have any issue with progesterone either, because lots of times the issues that are driving the difficulty becoming pregnant are related to low progesterone. And I'll
Mm.
even have some GYN, OBGYN colleagues who are like, we have common patients who are like, we just keep with the progesterone. Yes, they don't have an issue with it whatsoever. Do I just use it sometimes in women with that aren't in that perimenopause, menopause range where they suffer from really bad PMS or PMDD that are kind of younger? Yes, I will. Yeah. It's a game changer for a lot of women.
Mhm. Yeah, progesterone is really important. It's like the feel-good hormone.
It really is. It's underrated for sure.
All right, so to here, go back to cortisol, circadian rhythm, and melatonin. Any tips on circadian rhythm regulation for night shift workers who do those 24-hour shifts multiple days a week? Any
Yeah,
tips?
that's tough. It's tough because these are kind of the challenging patients because they're they actually well, the night shift workers tend to really like working night shift after a while, and they some of them just do fine sleeping during the day, and but it's the shift workers that sometimes do nights, sometimes do days, where it's challenging. That's where I do think that melatonin really does help out, because melatonin, it's great for the shift workers. It's great for, even if you're traveling, jet lag, you're all messed up with the time, melatonin does help out. You really do need a sustained release or prolonged release, formulation of melatonin. That's the best. And you really shouldn't need super high doses of melatonin. I have patients that are like, they've taken like 30 milligrams. For the use that we're using it for, it really shouldn't be that much.
Yeah. So that was the next question. What's the recommended dosing for full mass?
Yeah, so it's prolonged release, probably, like it really shouldn't be more than 3 or 6 milligrams.
And then any reason to not have long-term use of it? Is it supposed to be short-term? What's up with that?
I don't see any harm in using it long term. We do have a number of large scale research studies that show the benefit from an anti inflammatory benefit of melatonin. I think we get into a concern where is it becoming habits forming? I don't think it is. It's not like your others. I think it gets grouped into a lot of other sleep aids that we don't want to take it for long periods of time. It's a totally different ball game than any of those. So I don't see any harm in taking melatonin um, on a long-term basis.
Okay. Thanks for back to the topic of progesterone. What would you consider to be too high of a progesterone level? If any?
It's all relative. It's all if you have to look at the ratio of estrogen progesterone. I mean, if you're just looking at if we just say for the sake of because the urine metabolite testing kind of spells it out for you. If you're looking at serum testing, it really should it's 1 to 100. So I don't, yeah, I don't see any harm in there being high progesterone levels, unless, I mean, in my practice, uh, if it's too high, it's usually because they're on progesterone, and then that would be an indication to cut back if they're having problems. If they're like, "Hey, I sleep really good, but I can't wake up in the morning," well, then that's a problem. So that's a little too much.
Yeah. Got it. Got it. All right. I'm checking to see if there are any other questions. I think both the things we covered already. Oh, we got a thumbs up for this one, so let's show this one. So that means more than one person's interested in it. I've heard you do not want to take DIM if on BHRT, HRT, or already have low estrogen. Is that correct?
Well, there was a recent study that just came out on persons on HRT or BHRT and DIM, and they said perhaps it's not beneficial. That's brand new information. So it just taking to light that I would reconsider because you're using DIM a certain way for women, and if you're giving them BHRT, that should really be the treatment in that point. If you already have low estrogen, I mean, DIM's just a detoxifier, so I don't think that's gonna negatively impact low estrogen. So, like, I'm thinking someone who is postmenopausal and maybe, I don't see any harm in it. You wanna take into context the patient that you're working with, but, yes, that is recent data on the DIM and BHRT.
All right. Thanks for that. All right. I think that does it for us. Thank you, everyone, so much for joining today. Dr. Mazza, amazing presentation. Thank you for staying late to answer all the questions.
Of course, of course. I appreciate everybody's interest in this topic. It's an important one.
We totally, yeah. So thank you, everyone, for joining. See you again next week. And if you have any questions, let us know. Take care, everyone. This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.